Hi there, my name is Scott Yaris. I'm a professor at Michigan State University and also president of Stuttering Therapy Resources. I'm here to just do a quick video to talk about one of my favorite topics. I know I could go on and on about this topic, but I'm going to try to keep it short this time, and that is understanding the distinction between less direct and more direct treatment for preschool and young school age children who stutter. There's a lot written about this and a lot of discussion has been made about this. Here is the basic situation. There are some people who advocate less direct approaches to therapy for young children who stutter, and some people who advocate more direct approaches to therapy for young children who stutter. But I want to talk about a way to integrate and use both less direct and more direct approaches as needed for an individual child. First, let's talk about what do we mean by less direct approaches. Historically, all of the therapy in our field was what was called indirect at the time. I'll explain why I say less direct instead of indirect in just a few moments. But indirect therapy was therapy that was designed to help the child enhance its fluency without talking about fluency at all, without drawing the stuttering to the child's attention, without talking to the child about stuttering, without doing anything that might increase the child's awareness. So the work was done through the parents. Parents were educated about stuttering. Parents were educated about ways to enhance the child's fluency by reducing demands on the child, but the child himself was not involved. The reason for that was basically an older theory. You may remember from your studies the diagnosogenic theory that said that drawing attention to a child stuttering would cause him to become self-conscious, mislabeling his normal disfluency behavior as atypical, as stuttered, would cause him to become concerned, and that in turn would create stuttering. Today we know that that's not true. That's not how it works. But the fear of creating discomfort for the child who stutters drove our therapy and our thinking for decades, for decades. Today we know it's not true. And so the reason I talk about less direct therapy is because I don't know of anybody who does pure indirect therapy anymore, okay? People might work with the parents, but they're not doing it because they're afraid to talk to the child like we were once upon a time. It's just that we know that helping the parents reduce demands on a child can indeed enhance the child's fluency. We'll do that in conjunction with other things where we may work more directly with the child. So that's why I refer to less direct therapy. And there's many different approaches to less direct therapy. Many practitioners use them. And the idea is that we can identify those factors that make it harder for a child to communicate, work with the parents to reduce those factors to increase the child's success. On the other hand, the more direct therapy, well, there's a couple of different ways to do that. Of course, we know of more direct therapy or direct therapy that we would do with older children who stutter or with children who have other conditions where we would model an appropriate way of producing something, give a child the chance to try it the way that we produce it and give them feedback. Maybe for articulation therapy, you do some auditory bombardment to highlight the distinction between the adult production and the child's production. We're familiar with more direct therapy for lots of other conditions. That's one thing that can be done in stuttering therapy, though there's very little written about how to do that. Another approach to direct therapy with young children who stutter is an operant conditioning therapy approach, in which one praises the fluent speech, the desired behavior, and gently corrects the stuttered speech, the less desired behavior. The most common example of operant conditioning that you know of today is the LIDCOM program. And that's another more direct approach to therapy. So based on what I've told you already, you can see that, wait a minute, that distinction between direct and indirect isn't particularly helpful because nobody's all direct and nobody's all indirect anymore. We talk about less direct and more direct, but even so, instead of saying that there's a dichotomy here between less direct and more direct, I want to say, I don't know if it's a word, a trichotomy. There are really three different approaches, general types of approaches. Less direct approaches, more direct approaches, and operant conditioning approaches. I would separate out all three of those because although operant therapy can be called direct, and it has been in the literature, there's nothing wrong with that, it really doesn't have any of the characteristics of typical direct speech therapy like we might see for a child with a language disorder or a child with a speech sound disorder, right? When we do direct therapy for a child with a speech disorder, we're modeling the correct production. We're providing feedback about how to produce it. We are giving the child the opportunity to try it, and we are working to help them move toward correct production. But in LIDCOM program, in operant conditioning program, that's not officially part of the program. You're simply providing contingencies of desired speech versus non-desired speech, fluent speech versus non-fluent speech. So let's separate them to keep the distinction in our mind, because we can do operant conditioning therapy with young children, and there's plenty of literature addressing that. We can do less direct therapy with young children who stutter. There's less literature, but there's still lots of expert writing about that. All right. But we can also do more direct therapy, modeled after what we might do for an older child who stutters, but adapted to the needs of a preschooler. Okay, so now that we know that there are three different categories, we can come along to talk about how I might approach a young child who stutters. What I do when I'm working with a young child who stutters and his family, I am thinking about both less direct and more direct approaches. Of course, so much of what we do in our field is behavioral anyway. We're always doing some type of reinforcement. That's all operant. But I'm not just doing that. I am also looking at ways we can support the parents to create a fluency facilitating environment for the child, ways that we can reduce demands on the child in order to encourage his success in communication, ways that we can reduce stressors that he's experiencing that reduce his fluency to support fluency, and as needed, then working more directly with the child by helping him learn to make changes in his speech production as needed, and in particular, working to ensure that he develops healthy, appropriate attitudes toward his communication differences. Because although we want a young child who stutters to be able to recover, that's one of our goals with the preschool kids who stutter, we also know that not all of the clients achieve that. No matter what therapy approach you use, some young kids who stutter do indeed continue stuttering. And it should be the case. I want to make sure that the child has healthy, appropriate attitudes toward his communication, that he feels okay about himself, and that he knows that what he says is valuable and worthy of being said, regardless of whether or not it's produced fluently. So when I do therapy, I am drawing on both less direct approaches to help the parents and the environment, more direct approaches to help the child with his attitudes and potentially with his speech, and I'm doing so in an individualized fashion. See, in my opinion, there is no one approach that can apply to everyone. Canned approaches can't help everyone, plain and simple, and it is not consistent with the principles of evidence-based practice to use the same therapy for everyone. It makes me nuts when I see people say, well, I always start therapy with this, because that's not taking into account the unique needs of each individual client and family. So I have a series of approaches, a series of principles. So I draw from those approaches and principles as needed. Less direct approaches, more direct approaches, combined together in a unique package for each individual child and family that I'm working with. That's how I address the great debate between indirect and direct therapy, or less direct and more direct therapy. Now, I know there are plenty of practitioners who favor operant approaches. I understand that. I have some specific reasons that I take a different approach that I can perhaps address in another video. But for now, remember the most important thing. Individualized treatment is the key. There is no one approach that works for everyone. So that means that we need to do a comprehensive assessment. That means that we need to be looking at what factors affect this child, what factors affect this family. And anyone who tells you that they use the same thing for everyone is truly missing the big picture of the fact that every person who stutters, even little preschoolers, is different. Every family is different. Obviously, much more to say about that, and indeed, that's why I wrote a book. My colleague Nina Reeves and I wrote a book, Early Childhood Stuttering Therapy, a Practical Guide, covers this topic in detail with lots of direct treatment examples and goals. You can find it at stutteringtherapyresources.com. I'll be back with more videos later.